Hereby, I open this academic ceremony at Maastricht University. First of all, I welcome Mrs. Dorothy Lall. She will defend her academic thesis, Primary Care for Chronic Conditions in Rural India, towards a person-centered model. I welcome all the members of the degree committee, in particular the 4 supervisors, Professor Gesine Horstman. She is Professor of Philosophy of Public Health at Maastricht University. Professor Bart Kriel, he is Professor of Public Health and Health Systems at the Institute of Tropical Medicine in Antwerp, Belgium. The third supervisor is Professor Nora Engel. She is Professor of Global Health at Maastricht University. And a co-supervisor is Dr. Devadasan. He is Professor of Public Health at the Institute of Public Health in Bangalore, India. And of course, I will introduce the other members of the committee, but I will do that later during the opposition. And I welcome, of course, all followers of the live stream. Mrs. Lall, may I invite you to give a presentation and a summary of your dissertation? Please go ahead.
Thank you. Dear Pro-Rector, dear members of the Corona, dear colleagues, friends and family. In the coming 15 minutes, I would like to briefly describe for you my work during this PhD. The thesis is titled Primary Care for Chronic Conditions in Rural India towards a Person-Centered Model. I would like to begin by introducing you to Shanti. Shanti works as a hired laborer on agricultural land in a rural village of Karnataka in the south of India. She is the main breadwinner for her family. She looks after a family of 5, her children, her husband, and her mother-in-law. Her husband is mostly not at home, and her entire family depends on her day's earnings for their sustenance. Shanti developed a cough with persistent fever and weight loss a couple of years ago. She was diagnosed with tuberculosis, a fairly common condition in India, and was also told at the time that she had diabetes. She was given medicines which she took for 6 months regularly. After that, she felt fine and was told by the doctor that she could stop the medication for tuberculosis. She also stopped the medicines for her diabetes. No one had explained to her why she needed to continue this or what this condition meant. Recently, she developed a non-healing ulcer on her foot, a complication of her diabetes, and returned to the health facility, only to be told that she needed to go to a laboratory the next day to get her blood sugars tested. This began a series of visits till she was started on medicines. The problems Shanti faced are clear for all of us. She had financial difficulties in accessing healthcare. She is, of course, the only breadwinner for her family. There was poor communication by the healthcare provider that did not explain to her what this condition meant. There was no follow-up mechanism that could have brought her back into care once she stopped her medicines. The healthcare process that she finally did access was fragmented, requiring her to make multiple visits and go to a laboratory that was at a distant location. She was basically not empowered to care for herself, and most likely would continue with irregular treatment and poor follow-up. Chronic conditions are a leading cause of death globally. 1 in 6 people with diabetes in the world is from India. India is often called the diabetes capital of the world. 1 in 4 people in India have hypertension. Chronic care is challenging, as it's easy to understand, primarily because it requires a sustained engagement of a person with the health system over prolonged periods of time, often over the lifetime of a person. The reality also is that many patients do drop out of care, and even those that remain in care studies show low levels of control in them. Therefore, the aim of my research and thesis was to critically analyze the current processes of care for diabetes and hypertension, to empirically identify gaps in service delivery, to design interventions to address these gaps, then to implement and evaluate them in order to strengthen the delivery of services at publicly funded healthcare centers in rural Karnataka. The overall design of my study, I divided it into 2 phases. In the first phase, I did a situational analysis to understand what the current processes of care were. I also spent time with the primary care teams to co-design with them interventions that we would then implement. The remaining in phase 2, I implemented these, monitored them over a period of 9 months, and evaluated them to look for changes. Just to briefly tell you a little bit about where this research is set, Karnataka is a southern Indian state with several districts in it. One of those districts is Kolar district, where I worked. It has a population of about 1.5 million, so it's a fairly large district. Healthcare in India, and particularly in Kolar, is structured according to primary, secondary, and tertiary levels of healthcare. However, there is no gatekeeping, so very often people access secondary and tertiary levels of healthcare for primary care needs. There is the public sector, that is the government-funded public healthcare facilities, as well as a large and growing private sector. Almost 70% of people with chronic conditions like diabetes and hypertension that I mentioned actually access the private healthcare facilities. The way the public health system deals with issues of public health importance or of the magnitude like diabetes and hypertension that I described is through vertical programs. So we do have a control program for diabetes, stroke, and cancers called the NPCDCS, which is in place and describes a package of services that need to be delivered at each of these levels. Adding to the complexity of our health system is also the fact that different systems of medicine are practiced, and there are, of course, multiple providers of health in that sense. So coming to what I did, so in the first phase, as I described the situational analysis, what I did was to purposefully select 3 private clinics, that is in the private sector, and 3 of the publicly funded primary healthcare centers. I interviewed 6 medical doctors as well as spoke to several patients, conducted non-participant observations, also conducted facility assessments to understand fully the care processes. Further, I also searched the literature to understand how chronic care is modeled. And there are several models in literature that describe how we could structure and organize care for chronic conditions. A popular one among this is the one by Wagner et al., which I analyzed in great detail and also tried to assess its relevance to a low and middle income country like India. I went further to adapt it for application in India using a methodology called the best fit synthesis. I'll share with you briefly some of the key findings. So when I looked through literature and studied each of these chronic care models, I found that while all the elements of the chronic care model are applicable and very relevant to a low and middle income country context, these stood out as not being covered. And this from primary research in low and middle income countries was something often emphasized. The provider-patient relationship and communication, the availability of resources, very often medicines itself are not available, and coordination across various different providers, which is very relevant in our context too. Looking at the care processes in great detail, I found these to be doctor-centered, and when I say doctor-centered, I mean that most of the tasks that need to be done in the care of a patient are actually done by a doctor. That puts a huge amount of load on the doctor and centers the entire care process on the doctor. They're also fragmented in terms of not all being available at one place. It does not empower patients, health information is lacking, and there's no continuum of care. These are all the things that we already saw in the case of Shanti, but now I had empiric evidence to say what were some of the gaps in service delivery. Further, then I co-designed with the primary care teams that I was going to work with 3 public health centers, and I chose to work with primary healthcare centers, publicly funded ones, because that is the place that is accessible to the majority of the people who are poor, who are unable to access the private sector. And therefore, improving quality here was an important consideration. We together with the primary care teams, identified and prioritized these 4 interventions of the various evidence-based interventions that exist to rationalize the workflow so that the time a patient spends in a primary healthcare center is less. We distributed tasks, introduced clinical records, and of course build the capacity of the team. When I say rationalize workflow, this is the kind of complex workflow that was prevalent in most and is prevalent in most primary healthcare centers. I won't go into the details, but as you can see, the multiple loops indicate the number of times the patient has to return to the doctor after getting a small task done. This was then rationalized into something more streamlined and simpler and took much less time than the previous one. It also involved in identifying new tasks and identifying which person in the team would do them. Some of these were counseling, reminders and follow-up, informed decision making, and foot examination, which is often overlooked. We introduced medical records. These were paper-based records, not electronic records, but we also put these into place. For the evaluation, I used what's called a theory of change-based evaluation. We theorized on how these interventions would ultimately improve the outcomes or strengthen the care delivery. This provided me with a framework of what to measure to say that implementation had occurred, as well as to say if outcomes had improved. So I collected both quantitative data around process indicators and outcomes, as well as qualitative data to understand how implementation happened. Processes were implemented most at the second PHC, but after 4 months did not occur at PHC 1 and PHC 3. Follow-up was not as good as we would have liked, but was much better than what was happening. Most patients did achieve target control for their blood glucose and blood pressure. Implementation was very interesting to observe, and what I found was the presence of a care coordinator in the second PHC really facilitated implementation. That person became the contact person for the patients when they came in each time. Among the barriers, I found hierarchies within the medical professionals to be a very strong deterrent towards that inhibited team-based care. Doctor is usually at the apex of this hierarchy, and most people would look to him for directions instead of truly being team-based. What were the learnings and implications of this research so far? Well, it became apparent that perhaps a reorientation of our health services from an acute to chronic model, wherein medical records, continuity of care, sustained engagement with people all became important. A shift from the biomedical towards more people-centered services, facility-based to more community engaged. I also realized the importance of quality improvement teams. So we ended up playing a role of a quality improvement team, and that really, I think, could be a way forward in strengthening primary healthcare for chronic conditions. In doing so, also attention needs to be paid to hierarchies and leadership, team stability, primary care team stability, and perhaps an underlying statement of values. Based on these deliberations and these thoughts, I also propose in my thesis a possibility for a model of chronic care that is more community-based, less biomedical and more biopsychosocial, placing the person at the center and identifying these various interfaces where a little assistance could help people manage their condition much better. In the orange at the bottom, I also specify some of the values that came out strongly or importantly in my study about responsible leadership, about team-based and equality within the team. So in conclusion, I would like to say that if Shanti were to have this kind of healthcare delivery, she would not be overwhelmed by the long queues and the multiple visits to a facility. She would have meaningful interactions with the team, perhaps be able to partner in planning her own treatment and management, maybe have a health worker come visit her so that she would not have to lose a day's earnings when she visited the health facility. Maybe this health worker could also help her to identify and access social sector schemes so that it did not all depend upon that one particular daily wage that she would earn. Shanti would then be confident and empowered to live with her diabetes. With that, I would like to stop and I hand the word back to the Pro-Rector. Thank you all for your attention.
Thank you very much, Mrs. Lall, for your clear presentation. And if I see everybody back, we can start the opposition, and it will be opened by the chair of the Thesis Assessment Committee, Professor Trudy van der Weijden. She's Professor of Implementation of Clinical Practice Guidelines at Maastricht University, and I would like to give the word to Professor van der Weijden.
Thank you, Mr. Pro-Rector. Dear candidate, it was with pleasure that we've been reading and assessing your book, and it's just here, so the audience at the live stream can have a look on this beautiful, very You know, it's a brick wall book. It's solid work, and compliments for that. It is such relevant work, isn't it? I was a little bit shocked again by the burden of disease, of the diabetes and the blood pressure, elevated blood pressure numbers from your country. And I really liked that you brought it to us with the story of Shanti. Thank you for that. It makes it more livable for us, doesn't it? In this Karnataka Kolar district in your country. And you've been trying to apply then those theory of change, theoretical frameworks, like the sphere from Linda Damschroeder, and you've been using this music framework from Mrs. Kaplan. So compliments for that. It's a beautiful book, but it's such complex work, isn't it, to achieve the goals? So there are many, many questions that we would like to pose to you. I just choose some now for you. Let's try to phrase my first question. If I look at page 122, do you have the book there for you? Then
yes.
You can read again how ambitious you were phrasing on the top of that page your expectations from this complex co-designed intervention, like well, it will result in continuous care and the appropriate prescriptions for the drugs, and the counseling support will ultimately lower the blood pressure and improve the diabetes parameters, and this in 9 months, which is very ambitious, isn't it? So I think it was too ambitious. You've been viewing at some results, but I think these can be contributed or clarified by regression to the mean, and it's difficult to really say this is the result of my intervention. Can you reflect on why it was perhaps too ambitious? What are reasons that the blood pressures did not perhaps always really get lower, or the glucose levels did not reduce? Can you reflect on that, please?
Yes, thank you very much for that question, highly esteemed opponent. Yes, I agree with you that the overall scope and perhaps the outcomes that I propose to have measured were ambitious, and definitely 9 months was a little short period of time to see those kind of effects and changes. However, the theory of change kind of theorizes that if we were to do these things systematically, ultimately that is the kind of change that we would like to see. 9 months was too short a period of time, I agree. And in the design of the study, and it's a quality improvement implementation research design, I aim not so much to really see the effectiveness of my interventions on those outcomes. Instead, what was important for me to observe and to study was how this implementation took place, and how, because these are interventions that are evidence-based. There is already evidence for it in the literature, and these do make sense in the care of patients.
Yeah. Yes.
Therefore, the focus of the study, as well as of my interest, was to look at how this implementation kind of rolled out.
I agree. If you can already improve the processes, like the follow-up is improved and the care is more continuous and the prescriptions are more appropriate and the counseling is more appropriate. But still, could you give me some examples of factors or barriers that patients face to really get their blood pressure down or lower their glucose levels? Can you give me some examples of what might be barriers, even if the process went completely perfect?
Yes. So definitely when we talk about these processes, these are purely from a provider perspective and what is happening within a health facility and what we are hoping. But there's a whole lot of things that the person needs to do.
Yeah.
And a person is a person within a context, within a family and a community. So much as we would like them to modify their lifestyle, decrease their salt, take their medicines regularly, come in for regular follow-up, all of this may not always be possible given their local context. Like in the case of Shanti, she would have to forego a day's earnings if she were to come back regularly the way that we kind of prescribed. So all of those barriers to lifestyle modification are of course there. changing behavior, and also that changing behavior is difficult. It's complex, and there are several factors that kind of go into behavior itself. So that's why
I agree. Thank you, dear candidate. I notice that you are aware of all these other steps that need to be taken to reach these beautiful outcomes that are difficult to achieve. My second question perhaps relates to this, perhaps, I don't know, I'm just wondering. So I've been looking at your underpinned intervention, underpinned by all this pre-work in the earlier phases. And there was this, I have to look it up here, the accredited social health activists in your intervention planned. That really triggered me. I think that there's some potential, or there's beauty in these workers, I think, but it was difficult for you to really make them work. So you've been training them in the Primary Healthcare Center 1, but there was no real follow-up. And also 18 out of 25 were trained in the 3rd Primary Healthcare Center, but there were no means, as there was not a doctor to approve the training, or there were no financial means. So you've been clarifying all that to me, why they did not really get into this task of reminding the patient and helping the patient at home. Could it have solved your problem of the patients trying to adhere to all the prescriptions and the advices, these workers? Can you say something about it? Because these are not doctors or nurses.
If I understood the question right.
Well, just because the time is running, these social health activists, they do home visits for childcare. Okay, so they could have come, if they were reimbursed, they could have come home to help the patient. Okay, wow, I think there is beauty in.
Yes, they are usually incentivized, and their bulk of the work is actually maternal and child health. So making visits after a delivery, assisting a pregnant woman for delivery, that's the mainstay of their work. And traditionally, the focus in our health system has been on maternal and child health, understandably so, because that's a huge challenge as well. Most of their work is incentivized, which I, of course, was not able to do.
Yeah, I understand. Thank you, candidate. I'm satisfied with your answers. Thank you so much. And I give the word back to Mr. Prorector. Thank you.
Thank you, Professor van der Weijden. The opposition will be continued by Professor Muralidharan. He is Professor of Humanities and Social Sciences at the Indian Institute of Technology in Madras, India. Please go ahead.
Yes, dear candidate, I have a couple of questions. One is, you mentioned that this intervention was co-designed. I think your entire thesis, I see it as an effort to strengthen the delivery system by designing an intervention which is co-designed. Yet at the same time, you also said that there were some barriers from the physicians. So I just want to know, while they were part of the design of the intervention, yet you faced some barriers from the physicians who were part of the team. So I just want to understand that dynamics of it. I will have one more question, and then one specific observational issue. If you were to let the government, if you were interacting with the government now, and you made some suggestions about how to make the intervention effective. To be more specific, can you tell us what kind of training program would you give to the people in the primary healthcare ecosystem that would sensitize those who are engaged in the delivery system? You have to have some kind of policy as well as a training program package that will help us address the entire network of primary healthcare system. Okay, so those are the two questions that if I were sitting with you as a secretary to the government, I would ask, tell me, okay, then what we can do to enhance the training program. You know? And the third is very, very related to observational issue. You redid the scheduling, the movement of patients. And then how did you ensure that new schedule, pathway of patients was complied with? I mean, it looked like you had some people who did not comply with the new patient flow also. So what was is there a mechanism to make the patient move in a particular direction by having your own volunteers? Or I just want some clarification. Thank you.
Right. Thank you, highly esteemed opponent, for that. I'll answer the first question. So in your first question, you asked me why, although we co-designed the interventions in a participatory manner, yet we did face barriers in implementation, and some of it was because of the medical doctors. So in answer to that, I would say that yes, we co-designed the interventions and there was ownership of the interventions that we were going to implement. However, the barrier that was faced was more to do with actually enacting team-based care. So what came in the way, I think, was the hierarchies that are very inherent and ingrained within our medical professionals and among healthcare workers, which kind of places the doctor at the apex of this hierarchy. Therefore, truly team-based care in terms of being able to get all the team members on board in a participatory manner, truly delegating tasks and allowing them to do it, was very difficult in practice to do. So that's what I mentioned as a barrier. But yes, the participatory process did help in some of the ownership. They did try to implement it. We met monthly for monthly meetings to see how it was going, and they would often share these difficulties.
Could we say, therefore, it is a kind of effort that requires sustained effort to work in that fashion over a longer period? So it's like
Yes, I would agree with that. It's something that would require sustained effort. Your second question to me was regarding what kind of advice I would give to a policymaker. My answer to that would be that one is, of course, ensuring that resources are available, and we see that often resources are not consistently available. Things have really improved in our primary healthcare centers overall, and medicines and diagnostic glucose sticks, etc., are now available. However, they are not always consistently available. So one thing easily that can be done is to ensure that these things are in place, that the team that is there at the primary care level is stable. So there are not so many team transfers in and out of a particular team, because it helps with relational continuity. It helps because they have most of the information, they know these patients personally. So it helps in the overall care of a person. So these would be two easy things, I would say. The more difficult one, and what I found very useful, was this role of an external quality improvement team, and the use much more of quality improvement methods. One PHC at a time, each primary care team at a time, we were to work with them. Because often what happens, and what I also observed, is that the doctor is rather overburdened with the number of patients they see. So, and in that, then to spend and dedicate time for quality improvement and to think of how they themselves could improve the workflow from a patient's perspective is often difficult and maybe too much to ask. Therefore, the role of an external quality team that could assist them and help them with this, I think, would go a long way. It may not sound like it would produce results immediately, but I think that these small efforts consistently done over a period of time would definitely improve quality. So these are the few things that I would perhaps recommend to a policymaker overall. The third question you asked me is about training and what kind of training I would propose. So of course there would be the task-based training. So we did capacity building and needed to do that because the nurses were not very confident in what kind of advice to give, what counseling to give. So that kind of capacity building, of course, is a given. But beyond that, I think that our primary care teams need more inputs on understanding team-based care, on understanding, our doctors perhaps need to understand relational leadership and how to lead a primary care team in a manner that brings everyone to the table and treats everybody equally. So these are things that can be taught. There are some skills that go with it. And perhaps I would incorporate leadership into our training package for medical doctors, apart from an orientation, of course, of how to manage and how to handle resources available for improved care of people with diabetes and hypertension.
So if I have time, just one quick thing. So maybe you may say there are not many places where you can see collaborative work within PPHCs.
I have to interrupt you. Your time is up.
Okay. So we'll discuss later.
We have to move on.
Sure.
Thank you. Thank you for the questions.
Thank you, Professor Muralidharan, for your questions and discussion. The next opponent is Professor Josephine van Olme. She is Professor of Quality of Integrated Care at the University of Antwerp in Belgium. Professor van Olme.
Thank you, Prorector, and welcome, dear candidate. Indeed, it's a pleasure to see somebody putting so much effort in implementation research, an undervalued and very important domain of research, which you made that clear in your presentation. When I start from your research question in your thesis, the aim to understand gaps in care and understand which interventions can improve. In fact, it seems to me that you have grown into this field of implementation research. You started by specific interventions, and now you tell us, in fact, the interventions, I knew the ones, but the challenge was, how do you implement those? And you mentioned in one of the previous responses that hierarchy was the most important, crucial limiting factor in implementation, I think. When I go back to the frameworks which you used, because you say in my methods, I used theoretical frameworks and I took a complexity approach. And one of the key frameworks for this implementation is, of course, the CIFR. Is hierarchy, where in the framework is that positioned according to you? And how does that relate to the other elements in the framework or the other layers in the framework?
Yeah, thank you very much, highly esteemed opponent, for that. If I can just make one reference to the comment you made before about how you have also observed me growing into the question. So I would also admit that that is true. I also started with a very different way of thinking, perhaps a different paradigm. And this thesis and this PhD has been an opportunity for me also to look at many things differently. So I appreciate that comment. About the consolidated framework for implementation by Darmschroeder, it identifies the intervention as one of the aspects, and all the intervention characteristics as something that influences implementation. Also the outer setting, the inner setting, the implementation process itself and the strategies that are involved, and also individual characteristics. I would place or understand these hierarchies that I mentioned with the individual characteristics, and perhaps it also has a connection to the inner setting. That is how the actual inner setting operates, the very micro ecosystem, so to say, that also Kaplan refers to in his music, the framework that he also proposes. So there are interconnections of the individual characteristic with the inner setting, and that's where I would understand hierarchies to be placed. I'm not able to hear
unmute.
You.
We cannot hear you. Please unmute.
Sorry, yeah. You state that you use a complexity approach. I understand that you could not focus too much on the outer setting, but can you reflect from a complexity paradigm which outer setting elements would have influenced the inner setting in the implementation barriers or opportunities? And you could take hierarchy as one of the examples to elaborate that.
Yeah, thank you so much for that question. So of course, I think what complexity brings to the understanding of implementation also is this interconnectedness, that each of these, of course, are not isolated silos, but that each of them has a bearing on each other, and there are interconnections between each of these. So yes, definitely the outer setting had a bearing on several of these interventions that I tried to implement. The one that I would like to take an example of is perhaps the Asha Worker, the accredited social health activist, which we were discussing a little while earlier as well. Now, the outer setting or the external policies that kind of guide her work and the way that she is incentivized and the emphasis that's placed on maternal and child health, all of that became a sort of a barrier to my involving them much more for chronic care, and asking them to visit homes and give follow-ups and reminders. So there was a definite influence of the external policy environment, the overall policy that kind of guides their work, which directly influenced an intervention that I was trying to put into place.
Okay, then I continue to the next page, on page 153, where you discuss the strengths and limitations of your approaches. And you say that these theoretical frameworks allow you to draw inferences to similar settings. It's clear that you have really got an in-depth understanding of one particular setting, yet you do claim that there is more validity also to outer settings. Could you reflect a bit on what would be the meaning, and could you give examples to which other settings that could or could not then apply?
Yes, thank you very much for that question. So the way that I understand how a theoretical framework would help in sort of gleaning some results that could be applicable in different settings, and the use of the consolidated framework for implementation research that I used in this case precisely helped me to do that. What I would think it helped me with was to situate what I was seeing or what I was finding in this larger. So the consolidated framework for implementation research has been built on a whole lot of literature and different experiences from various different contexts, and has then identified these many constructs that have that make up or influence implementation. So being able to situate what I was finding within this larger framework then allows me to understand a different setting also if I were to use a similar kind of framework. Now, the local context, and of course my study was very locally contextual, but if I was to go to perhaps a neighboring district as well, let alone another state and another thing, the context of course is different. How teams operate are different, the kind of policies that govern them are different. However, I do know that these then become important, and that's what I understand from having applied a theoretical framework in this setting, and I would perhaps then look for the same if I were to do this in a different setting. So that's how I understand the theoretical framework helps.
Thank you very much, Candidate. My time is finished for this round.
Thank you very much, Professor van Olmen. The opposition will be continued by Professor Stef Kremers. He is Professor of Health Promotion, and he is also Vice Dean of the faculty at Maastricht University. Professor Kremers.
Thank you very much, Mr. Pro-Rector. Dear candidate, let me start with giving you my compliments for your great work and also the very clear presentation that you gave on this very, very interesting and necessary series of studies that you did. Really great to read. I also like the discussion up to now, and that prompted me to pick up on the discussion that you had just had with the previous opponent, Professor van Olmen. Because I also see the evolution that you made in your thinking, becoming more and more holistic throughout your thesis. And let me start with asking you to read out proposition number 6. I hope you have your propositions in front of you. Please read out your proposition number 6.
If you could just give me a minute, I'm sorry, I don't have it open. Yes, The proposition number 6 about the key to tackling the epidemic of non-communicable diseases lies in addressing the social determinants of health, like tobacco control, provision of means for increased physical activity, and access to healthy foods. We need to refocus on the underlying social causes of ill health rather than focusing only on changing individual behaviors.
Yes, so the underlying social causes of ill health, and this is really, I think, key to your work and also key to your redefined proposed model of chronic care, right? Because there you really have this very upstream holistic view of causes of health, and especially your sectors other than health that you included in your model that I see on page 159. It is clearly illustrated. Knowing that and going back in your thesis and reading again chapter 4, it seems that chapter 4 was actually designed quite narrowly. So not very holistic, but pretty narrowly on the inner setting that you just referred to Professor van Olmen. So I'm asking you now, if you could redesign chapter 4, your research there, knowing your social causes of ill health, your holistic view on prevention and treatment of chronic diseases, how would you redesign chapter 4?
Thank you. That's a very interesting question, highly esteemed opponent. Yes, like you appreciate, there has been a lot of change in the thinking, definitely, and also this understanding of illness and a person, and therefore this attention to the social determinants of health. How I would redesign it perhaps would be to think carefully of the interventions that we were making. These were, of course, from a very provider facility-based kind of interventions that I made. Perhaps I would have included some others that extended beyond it. However, given also the limit of the time that within which I would have to achieve and complete the study, I don't know entirely if it would have been very feasible, but yes, at least I would have been able to think through the inclusion of perhaps addressing one of the social determinants, perhaps.
Okay, and would you also interview other stakeholders, other persons than the persons that you interviewed now?
Yes, definitely. So mainly what I have interviewed in understanding the care processes has been provider perspective. So it has been the doctors, it has been the nurses and the primary care teams, as well as looking at it from the understanding the implementation processes. Also, I interviewed mainly the healthcare providers. I have also interviewed patients, of course, but these patients were all interviewed within the healthcare setting, and these were interviews with the patient. But of course, understanding that a patient is a person in a social context, in a family, in a community, definitely also interviewing family members and understanding from community members how they perceive it and how they understand chronic care would definitely have enriched the overall understanding.
Okay, so family members, maybe also some other professionals? Professionals from other sectors than health, for example, as you mentioned in your proposed model?
Yes, of course.
Which ones?
Yes. So of course, I also received inputs for this, and my own understanding grew definitely by inputs from the social sciences, and I received several inputs from that. So having a social scientist, for example, on the team would have really helped. What would have also helped me to understand since organizational culture and the way that the team is organized and how the team behaves came out to be a really important thing. I think somebody with expertise in management sciences perhaps would also have helped me to understand this implementation that was happening at the primary healthcare centers and how organizational culture really influences that. So
okay, and I know that this would be difficult, but if you would have done it like this, how would it have changed or maybe changed the interpretation of the results that you found? If you would have had this broader contextual view on the implementation process?
It would have changed the view if I can go back to the consolidated framework for implementation research and see that it then would not have been so narrowly focused on the inner setting, and perhaps would have also given me sight and the insight into connections with the outer setting and the larger context of the community, family, as well as the broader context of healthcare itself. That would have, I think, enriched my understanding overall.
Okay, yeah. I think I agree that it may even have helped explain the behavior, for example, of these, let's say, horrible doctors in some of your places, for some of your settings. Sometimes it really helps you to explain the behaviors, or maybe explain the impact of certain behaviors. I'm really glad with the answer that you just gave. So with that, I give the word back to the prorector.
Thank you very much, Professor Kremers, and thank you also for being the secretary of this degree committee. The next opponent is Professor Karina Kilmann. She is Professor of Equity and Health at the Institute of Tropical Medicine at the University of Antwerp in Belgium.
Thank you very much, Mr. Prorector and dear candidate. I really enjoyed reading your thesis. It resonates with a lot of work I've done in India, so I was very pleased to have the chance to look at this. I wanted to start with your best fit synthesis, which I thought is a really appropriate way to go about reviewing the literature here. You looked at elements of the chronic care model as applied to a range of studies, and you concluded by saying that there are certain elements that are missing, which are relevant for low and middle income settings, specifically communication, decentralization of healthcare, and the issues around lacking resources. So I would like to know a little bit more about how the kind of insights that you gained from that review, plus your formative research, fed into an adaptation of the interventions. Because when I look at your interventions, I can't see necessarily that they're adapted to the context. So I'd like to hear a bit more about that. And that's, a little bit about the co-design process as well.
Thank you. Thank you so much, highly esteemed opponent, for that. While the literature review and the understanding of the chronic care model and things that could perhaps relevant in a low and middle income country context enriched my own understanding of how we could go forward with this, some of these elements were of course captured in what we called team-based care. So the task shifting and involving other team members was also aimed at improving the provider-patient communication and placing some of the stress there. The access to, meaning the availability of resources, for example, is something that we discussed with the district health officials, and it is something that we kind of already ensured would be available throughout this period of time. And like I said, things have really improved in India. So to some extent, at least medicine availability and the availability of the diagnostics was also thought of in the process of designing the interventions. These were the two main things that kind of stood out from the best fit kind of synthesis. And of course, also what came out from the best fit synthesis was an understanding that all the other 6 elements were extremely important. So we took, of course, portions of that as well. The health information system that we put into place is something already prescribed in a chronic care model. So there was elements of that. Plus, I would say the emphasis on provider-patient communication through team-based care, and giving space and time for patients to interact with other members of the team, as well as ensured, that we went and made sure that resources were at least available for the period of the implementation.
Thank you so much. I'm going to push you a little bit on that one. So some of the interventions that you propose are actually suggesting quite radical changes, right? To the normal, as you said, organization of care, to the hierarchy of providers, to the way things operate in the Indian medical system. Now, these insights that you gained at the end of the research, which was that teams weren't necessarily as cohesive as you assumed. There was a hierarchy that was impeding implementation of things. These are things that you possibly would have known already at the outset, right? Because there's quite a lot about medical paternalism and so on in the Indian medical system. So I just have a question about, given what you know now, or what you gained on local contextual factors that impeded successful implementation, do you think you might have done your formative research differently, or would you have thought about your interventions differently, given what you know now?
Yes, that's also a very interesting question. Thank you for that. Perhaps I would have thought of it differently, but like you say, these are not things unknown to us. Of course, understanding this firsthand and being able to see how it operates and how it is impeding the team-based care that we wanted to implement was something that this research kind of gave me an insight into. Having had this insight now, if I were to design, so I don't know if I was, at the start of it, would I have done it differently? But yes, with this insight now, I think that I would design interventions to address some of these at the very beginning. So perhaps some of the time that I spent in preparing the teams or in preparation with the teams would have been devoted to talking much more about team-based care, about an underlying statement of values, perhaps that could be a shared value statement, as well as how team-based care operates and how each person has something to bring to the team, to the care overall. So yes, I would perhaps do that differently.
Great, thank you so much. And just a last point on your theory of change. I noticed that the theory of change is very much oriented around the outcome, patient-oriented outcome. So reduction in blood pressure and glycemic values. Do you think that instead, were you looking to change outcomes for patients, or were you looking to change outcomes for the service delivery? And if your theory of change had been based around service delivery outcomes, would that possibly have been a different way of reducing the ambition in terms of the thesis?
Yes, I completely agree. But I would also like to say, as I shared before, that when I started out with the thesis, there was, of course, when I started out with the research, there was a certain way of thinking and a paradigm that I also came from. Much of this was dictated by that, and therefore perhaps the ambitious outcomes. But yes, through the PhD, I also saw it a different way and perhaps shifted a paradigm in my own thinking. And yes, I would agree that perhaps I would not choose the same outcomes were I to do it again.
Great, thank you so much. I think we're almost there. Maybe one very small point, just to challenge you a little bit on the disease-illness distinction that you started off with. So I think you're opting for an illness-oriented patient-centered care. But I just have the point about, disease labels sometimes empower individuals to take control of their condition, and they may destigmatize a condition. So I just wanted you to reflect on that very briefly in the context of India's very pluralistic system.
Yes, thank you again for that extremely insightful comment and question. I would completely agree with you. However, in the larger context of how disease is viewed and how the entire orientation of our health systems and our organization of services is so biomedical, I would still argue to move away from the disease orientation so as to move towards a more biopsychosocial, more holistic, more person kind of care. I hope it is not at the cost of what good or benefit disease labels bring, but I would think in the larger picture, perhaps moving away from the biomedical orientation is perhaps what's required today.
Thank you very much. I'll hand over to Mr. Prorector again.
Thank you, Professor Kilmann. The opposition will be continued by Professor Mary Hartley. She is professor at the Maternal, Child and Community Division at Rwanda Biomedical Center in Rwanda, and she is also affiliated with the Global Health Program at Maastricht University. Professor Hartley.
Thank you very much, Director. And thank you, dear candidate. It was a lovely piece of work to read, very well thought out and a very current and very relevant topic. I like that you use the perspectives of Paul Farmer, who tragically passed away here in Rwanda last month. Equity of access and context. I found that you are very careful in your choice of tools throughout the research. As a result, they proved to be very appropriate in answering your research question. So I had 4 questions if I have time, let's see. But they're mostly related to the use of your findings. The translation of your research into policy and practice is what is interesting to me. So the first question is related to the use of existing practices in other public health programs that require a continuity of care. HIV and TB particularly come into mind. The HIV focus on 1990, the DOTS program for TB, they've all required this continuity of care, this downward task shifting. And they work in many countries with the constraints that you found in your research. Family planning is another example. When I looked myself into how lessons from other community programs could be applied to TB control, I found that the lessons were even outside the health sector were relevant. And as we heard from Professor Kramers, it's also, NCD is also beyond health. Even the private sector, how did Coca-Cola get its bottles to the remote areas without stockouts? They use people, they use transport, they use very much the same inputs that are used for health. So I wonder if you could reflect on the possibility of that experience from the other programs that require the same continuity of care, and the private sector even could be leveraged to be equally successful for NCDs that are thankfully not stigmatized as HIV and TB are.
Yes, so thank you for that question. Of course, there are many lessons that we can learn from various of these programs, and one lesson that you already mentioned, which also I think is very relevant, is the decentralization, first of all, of healthcare delivery, and the use of various different healthcare workers in helping people care for their own conditions. Particularly, you asked me about the role of private sector and how that can be integrated or built upon for the care of chronic conditions. Definitely there is a role, and especially contextually in India, like I mentioned, 70% of patients actually do access the private care. So, and I did also study, do the situational analysis in private care facilities. So definitely putting into place standards for the care is one way in which we could kind of improve the care that is being given also in the private sector, but definitely partnering with them much more so as to enable that coordination across different providers, the public sector as well as the private sector partnering with each other, I think is one way forward. The use of course, family medicine physicians and others who look at it more in a more person-centered manner is also perhaps relevant. There are, of course, several examples within India itself where these have been tried, and there are good examples of private organizations that actually are able to deliver this kind of care. So I would say, yes, that there is a huge role for this, as well as perhaps is required going forward.
Thank you for that reflection. So my next question then is you refer to the importance of context in your study, and you rightly point out that the study findings were not generalizable to low-income countries, in themselves a diverse group of countries with even more diverse areas and people within them. But also not within India itself. And you demonstrated that this continued research, like the action research type of model, was more appropriate than the case control study for those reasons. Each of your primary health care settings, because of the staff that were involved and the hierarchy that's played out differently in each setting, they showed a different outcome. So I wonder, could you reflect on how this in itself was a finding, that every context, down to the departments, even within a single facility, have their own characteristics that would maybe require a different approach, not a standard one-size-fits-all approach?
Yes, thank you very much for that insightful comment. So yes, I completely agree that a lot of this is driven by the local context, and the particular dynamics of a team, even between 3 primary healthcare centers in a similar kind of setting in rural Karnataka, actually behaved very differently. And yes, that we do need to tailor and adapt interventions, and one size cannot fit all. I think the implication of this going forward is perhaps, like I was mentioning earlier, the role of external quality teams. So teams that can work with one primary care setting at one time and adapt interventions that we know to work to fit that local context, and work with the team in a participatory manner, I think is the way forward to finally bring about change. Like Braithwaite et al. Also argue that how we bring about change and how we think about change, perhaps in healthcare especially, perhaps needs to change. Perhaps it is these interactions between people and the small changes that will finally result in larger changes.
Thank you very much. And I believe my time's run out, even though I'd love to spend the next half hour just talking to you about it. It was very interesting. But Prorector, I think my time's run out.
Yes, indeed. As we have seen, dear candidate, Mrs. Lall, your time for defending your thesis is up. The committee will now withdraw to discuss the quality of your thesis and the quality of your defense, and I request you to await our return with the results of our deliberation. Mrs. Lall, I hope you can hear me. The degree committee here present online has assessed the quality of your thesis and the quality of your defense. And in view of its positive verdict, and also taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Horstman is authorized to confer upon you this academic distinction in accordance with Dutch university custom and law. And I invite your supervisors now to take the floor. Professor Horstman.
Thank you, dear Pro-Rector. Dear Dorothy, first I would like to ask a formal question before we can hand over the grade. Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
Yes, I promise.
Thank you. Then, by the authority vested in us by law and in conformity with the decision of the committee here present online, I hereby confer upon you, Dorothy Lall, the degree of doctor and grant you all rights attached by custom and law. And as evidence of this, you will soon receive the degree certificate signed by the rector, the secretary, and the supervisor affixed with the official seal of the university as shown by the beadle. No. Congratulations, Dorothy. It's over, it's done. You did a really great job. I'm very happy that you did. Bart will now speak to you.
Dear Dorothy, my sincere congratulations with your PhD. Outstanding work and an excellent defense. I'm happy for you and your family and feel very proud myself. Dorothy, there is this popular saying in Dutch that one voices when somebody feels really proud about a performance, a great performance of a family member, a friend, a close colleague, and that is mijn neus krult. Literally meaning my nose is curling. Well, today, Dorothy, my nose is curling. I'll have to push it back regularly. I still remember our first conversations in Bangalore. You started with excellent credentials. Staff member of the Institute of Public Health in Bangalore, by now a top institute in health systems and policy research in India. At the start, you were still a bit uncertain about the what and how questions. And indeed, your background was that of a medical doctor with expertise in clinical medicine and, between inverted commas, hard biomedical and epidemiological research. One sometimes says that a PhD is also a transformative process, and different opponents in the course of the defense have already pointed to that. This has certainly been the case for you, Dorothy. You gradually transformed into a versatile researcher with new competences in the field of health systems and policy research, embracing complexity and acquiring a broad systemic view when looking at healthcare delivery systems. You have coordinated courses in health systems and policy research at the level of the Indian Health System Transformation Platform. You organized teaching programs at the Institute of Public Health in Bangalore. And colleagues of you, Dorothy, talk of you with great esteem and applaud your modesty, your courtesy, and your hard work. All of this has been done in conjunction with a PhD. Wow. I will remain with a very nice recollection of our work together, our many working meetings, my field visit to Kolar district in Karnataka, but also the pleasant time spent with your family, an opportunity for me to meet your husband, Jesus, who is a cardiologist, your two beautiful children, Dia and Rayan, and your parents. Dorothy, you are a lady with style and class, a living illustration of the great Indian culture. But Dorothy, you know it better than I do, a PhD is a long journey with ups and downs. On the one hand, peaks of professional satisfaction and legitimate pride and happiness with recognition and praise by your peers. Dorothy, you are now fully part of the academic community and have become one of the experts in the management of chronic illnesses in India and beyond. But do not be mistaken. A new phase of work starts now. You will from now on increasingly be contacted by a wide range of people inviting you to work with them. Other academics, public health authorities, and younger people who themselves may have the ambition to go for a PhD and would want you to be their supervisor and coach. From now on, Dorothy, your professional career is taking a new start. But on the other hand, Dorothy, a PhD has also its downs. It's by times a lonely ride. And there have shortly been moments of writer's block, of fatigue, and of doubts. Moments where one would almost curse the PhD because of all the consequences it has on one's own life and on the lives of beloved ones. But Dorothy, today all this is over. There is a new horizon now with new and exciting perspective. Now, what I just said now are considerations, musings from the perspective of myself and I think also to some extent of your perspective. But how does family live all this? And more in particular, what about your children? And what about your husband? Well, I have to confess something, Dorothy. I have been mailing a bit behind your back with your husband and your children. Yes, we did. And they have shared with me short pieces. The first one is a short piece written by your most talented daughter, Dia, who I was told by her proud father has already published a couple of novels. So I'm reading out what Dia wrote about the PhD. I still remember the day Mom told us she was going to do a PhD. At that time, I didn't really know what it was, but I was quite startled anyway. And then one day, she just started working on it. I don't really know how, but suddenly the PhD was part of our lives. Since that day, Mom has tested out several speeches, bits of writings, articles, presentations, and elevator pitches on us. Consequently, I have learned a lot along the way. It has been a mad ride, the definition of a roller coaster, in fact. And yet I think I secretly sort of enjoyed it. On innumerable occasions, Mom was extremely tired, annoyed, frustrated, whinny, or just not in the mood for anything. But she still would meticulously make sure that we did our homework and our uniforms were washed, ironed, and ready for the next day, among the many other little things she did all the day. The fact that she was working on a PhD never really seemed to interfere with our movies on Saturday afternoons and our board games or the Saturday morning pancakes or our walks or anything else that we did with her. Somehow she always managed to make time for us. And of course, always we had time for her. But yes, along the way, there have been some days that I cursed the PhD and her thesis, especially when I felt like it was fighting with me for mother's attention. And Jesus himself also sent me a few lines on how he perceived this PhD adventure. For the sake of time, I'm not going to read out everything, but I picked three very interesting messages. Jesus writes, many things can be said, but what I would want to highlight is that the process of Dora's PhD has been an enriching experience for us as a family. Our children were quite young when she started her PhD. So for at least 2 months of the year when she was abroad, I had the privilege, he says the privilege, there are many witnesses now, of cleaning and bathing the kids, reading bedtime stories for them, feeding them, washing and ironing their clothes, and also having some fun exertions with them. Considering our cultural context, I'm fairly certain that I would have missed out on this had it not been for the necessity. He further writes, though I did not do a PhD, having conversations with her about things she learned or perspectives she gained by reading or from her colleagues and mentors also broadened my thinking as a clinician in this age of hyper-specialization. So you've infected your husband a little bit with this systems view. It's very contagious. Finally, he writes, well, there's a lot to be grateful for. There have been few times when I've wondered if the PhD took away time which belonged to me and the kids, whether it was the other man in her life. Before ending, Prorector, let me take the opportunity to thank my colleagues, Klazine and Nora, from the University of Maastricht, and Deva and Prashant from IPH for the very nice collaboration all over these last couple of years. It has been a pleasure working with you and a great learning opportunity. And now I finish with wishing you all the best, Dorothy, and express the hope that in the future we shall meet again, be it in Belgium or in India. I wish you the best of luck.
Esteemed Dr. Lall, dear Dorothy, it's my great pleasure to congratulate you with your doctorate and the honor that you have acquired today. And I do that also on behalf of the Board of Deans of Maastricht University. I would like to share some impressions of the committee with you. We enjoyed a very clear and good presentation. And also we have seen an excellent dissertation in terms of content, in terms of relevance, in terms of layout. And it is really beautifully, it has a beautiful layout and it is very well written. And we have also seen that the work, your scientific work, has been published in good journals. And it showed a very good scientific quality. In your defense, we have seen a very adequate defense. And maybe I may to summarize it in a few words. Critical, honest, translational, responsive, reflective, and very specific. And I congratulate you with that result that we saw today. And I also would like to include in my congratulations your 4 supervisors. 4 supervisors is quite a lot. And I think they may be proud of what you have shown today in terms of your presentation and your dissertation and your defense. And my congratulations go to Professor Klaasien Horstman, to Professor Bart Kiel, to Professor Nora Engel, and Professor Devadasan. You may be proud of this young doctor. Of course, I include in my congratulations also your husband, your children, your parents, and other members of your family. And also, I would like to include all your colleagues and all those people you have worked with and have contributed to your publications and to your dissertation. And I wish you, of course, a very successful professional career and a happy personal life. I'd like to thank all the members of the committee, of both this degree committee, but also of the thesis assessment committee. And in particular, I would like to thank the external members and all opponents for their questions. We really appreciate your contributions to both committees. And hereby, I close this academic ceremony.